I am sitting here with Lisa Mangino. She is one of 3 PRI scoliosis experts. They are the go-to people for scoliosis information as it is seen from a PRI perspective or in general. She also teaches the final day, or she's one of 3 teachers on the final day of the 4-day advanced integration course that takes place every year. It is a well-attended course. Tons of information. The last day is devoted to scoliosis. So it is obviously a big deal in the PRI world. And again, as I said, she's one of the 3 scoliosis experts that all PRI people will look to for information, including myself. So Lisa, why don't you just introduce yourself, where you're from, where you're practicing, and your background, and how scoliosis actually became one of your passions.
Sure. Thanks, Neil. I really appreciate, and I know my coworkers do too, the opportunity to talk to you and your listeners and just get some information out there about scoliosis, our passion. So I live in Durham, North Carolina, and I work at Advanced Physical Therapy in Chapel Hill with Jean Massé and Susan Henning. And the way I kind of got interested in scoliosis was kind of organic. Susan had a passion for it to start with, and she kind of came to Jean and to myself and said, hey, there's this course you can get in 9 days. It's called Schroth, and you can be certified, and I think we should do it because it would work really well with postural restoration. And so we all went through it. We went through the 2nd level and obtained the advanced certification, and that was back in 2014, 15, ish. So the rest has just kind of been history, and we've just been working with it since then.
Okay. Were you already, so you had been doing PRI and physical therapy in general before you really went, really start to not specialize, but really went deep into scoliosis?
Yeah, so I'm traditionally trained as a pediatric PT,
Okay.
and through my own personal experience with musculoskeletal malalignment and pain, found PRI through
like most of us do.
Right, like most of us do. Kim Kaiser was the one who introduced me to it, and she really helped me with it. And so I learned the patterns, and then I began looking at my caseload and my kids, and I'm going, oh, there's the pattern.
Oh.
Sure enough. So I started doing it with children from there. And then I left that major medical center and I went to a private practice where I met Jean and Susan and kept doing the kids, but that's when the scoliosis focus came into.
So you saw that connection immediately. Were you sitting in a PRI seminar one time saying, this looks like the scoliosis that I see in kids? Is that kind of how you made that, like, wait a minute, this is...
I mean, it happens. It's an asymmetrical pattern, and the pattern that a PRI appreciates is very similar to the pattern that we see in patients with scoliosis. So, 90% of curves go to the right at the top and the left at the bottom.
Okay.
90%, that's huge. That's not an accident. There's a reason for that, and we appreciate that it's chiefly attributed to organ placement and the way our hemispheres are wired and the way we use our brains and our asymmetrical patterns.
Okay, so in light of that, the similarities between this left AIC, right BC pattern, which anyone who watches this channel will be familiar with at this point to at least some degree, how does that relate to scoliosis? I mean, you just said that they're very similar in the sense of the direction which the curves are going. So what is scoliosis? Because a lot of people, not a lot, but enough people have said, is the right BC pattern just idiopathic scoliosis? And I say maybe, because I don't know enough about it. So this would be a great segue into really explaining what scoliosis is, and just give it back. Just tell us about scoliosis.
So in general terms, just to start kind of in general, we'll look at the forest and then we'll maybe see how many trees we want to take a look at and how much detail we want to get into. But it's a 3-dimensional torsional problem. Okay, so a lot of parents
will explain torsion.
I'm sorry?
Can you just explain what torsion means?
So torsion is just a twisting. If you watch part 2 of this 3-part series, my coworker Jean is going to do a really great demonstration of a 3-dimensional spine and twisting. So I started to say that when you look at an x-ray, you see an S or a C, and a parent's first, thoughts are, oh my gosh, we got to do something about this. But it's not just that picture of an S or a C, because we're 3-dimensional people. Right. So there are changes that happen in the front to back plane, the side to side plane, which is what you see on an x-ray. But then there's also, if you're looking down, there's also rotation. So shoulders, you're looking down, and hips might not be like this. Now they're kind of like oppositely rotated. Right. So think of a spine in a 3-dimensional system. It's not just curving. It's kind of shifting forward and rotating and twisting opposite itself. So that's where you get the torsion and the stress and strain that goes through it. Okay. And by the way, we all have a little bit of asymmetry, and we all have a little slight bit of a deviation from the midline. And it's not even considered to be scoliosis until it gets to be about 10 degrees. 10 degrees. Okay. And that measurement is the Cob Angle measurement. So that's a really...
No one understands.
Okay. Many people may not. It's easy to get the Cob Angle confused with a scoliometer angle, and I'll kind of differentiate the difference. I'll explain the difference. So when you have that x-ray and you see an S or you see a C, the vertebral bodies start to tilt and they start to kind of get out of alignment. We can draw lines on the most tilted at the top and the most tilted at the bottom, and then draw perpendiculars and use some angles and measure the angle of that curve in the side-to-side plane. Okay. But there's also this, so that's the Cob angle, and that's the angle that the doctors will use to say, okay, it's 20 degrees, let's try to think about putting you in a brace. 2025, it's 30, it's 40, it's 50, let's talk about surgery. Those are the angles that the doctors are using to determine treatment, so to speak. Okay. But another angle, and another, I'll use my rib cage here. So perfect. Here's the spine, and I'll just try to demonstrate. It starts to deviate, it starts to rotate, and as it rotates, if you look at it from this, so when a person bends over, when you look at it like this, you see one side gets a little higher and one side gets a little lower. Okay. Right? So we have to keep in mind that this rib cage is one system, and anything that happens to the spine is going to be reflected in the rib cage. Right. And that's where you get that rib prominence. And generally, so to me, this is the right side. I don't know if it's flipped to...
Oh, it's the right side, yeah.
Viewers. Is this the right? Okay, good. So here's the right side, and you can see that's where the prominence usually is when it deviates when it goes to the right side, when it curves to when I look at myself, it's opposite, when it curves to the right side. So anyway, so you bend forward and you see this hump. Okay, we don't like to use the word hump with patients just because, it's not so nice, but you see this kind of bump or prominence. Then you put a level on their back called a scoliometer, and that's what measures the angle of rotation. So trunk rotation.
And they're in a like a forward.
For a forward bend, it's the Adams forward bend test, and that's what we can use to level or to quantify how much of a deviation that rib cage has. Okay. And so the Cob angle is generally upwards of 20. The scoliometer angle is generally in the low single digits or teens. When you start to get into rotation of 20 and up, that's probably going to be a pretty darn big curve.
Okay, so you're saying that with the Cob angle, anything greater than 10 starts to be of concern, and that's where people need to start to really worry, in a sense?
Well, that's when it's defined as scoliosis.
Okay.
And that's, you're going to see a scoliometer reading before you're going to see a Cob angle usually, because you have to take an x-ray to measure a scoliotic spine. You have to be exposed to radiation. So there has to be a reason why a doctor would say, let's take an x-ray. Okay. Sometimes it's found because they might have think they broke their collarbone or some other problem, and then they might find it. But generally, it's that Adams forward bend test, and schools used to screen for it. I'm sure some schools probably still do, but many schools don't. That's the indicator. So you see that deviation in the rib cage as you bend forward, and 4 to 5 degrees is kind of the magic number for when you want to say to a young person, we might want to just take a picture and see what's going on inside, meaning take an x-ray.
Okay, so anything over 10 with the Cob angle.
Yes.
And then once you're approaching 4 or 5 degrees with the Adams, you said, is that what's called? The Adams forward bend test?
The Adams forward bend test, and using a scoliometer to, I apologize, I don't have one here, it's in the clinic, and because of COVID, haven't been going to the clinic that much. But it's just a rectangular level.
Yeah.
Basically, you can get an app, you can get an adjustment for your phone that has a little notch cut out for the spinous processes, and you can get an app on your phone that has the level, like an app that is a level. And as long as
parents can measure their kids at home,
they can. I mean, they can purchase a scoliometer, or they can get the little adjustment for their phone too, either way.
All right.
I do have a couple parents who like to keep track, which is helpful, especially now that I'm not able to measure them quite as frequently because of COVID.
Definitely. All right, so that's an overview of what scoliosis is. And so what I want to know is who tends to get it, and so you already explained exactly what you're looking for in terms of the curves. So who are the people that are more likely to get it? And for the people who are more likely to get it defined as scoliosis, or people thinking it's scoliosis, are those people definitely going to progress to a greater curve? Is there going to be a progression to it? Or can it be prevented from getting more extreme?
Right. So let's first just say that, there are a couple different categories of scoliosis. So you can have infantile, juvenile, adolescent, all idiopathic scoliosis.
And idiopathic means what?
Idiopathic is just that we kind of really don't understand why it happened. So it's not related to any other disease, process, injury, or reason. It's just all perfectly healthy and fully functioning young person, and all of a sudden, what is that bump on your back? And it's the rib cage starting to demonstrate that deviation. Juvenile, the cutoff is usually about 9 to 10. Once they're 9 to 10, then it's considered to be adolescent scoliosis, but sometimes they find it at age 11, but maybe it started when they were 7 and you just have no way to know. So there's a little bit of a gray area in there.
Okay.
And then there's kind of adult onset scoliosis. So juveniles is adolescence is anywhere from 10 and up through maybe 18-ish. And then after you get skeletally mature and you're starting to move into adulthood, you can still develop a scoliosis at that point, whether it be from an injury to your spine or vertebral wedging or a disc pathology. Things can start to change. Or once you're older, there's a category of de novo, or kind of just degenerative scoliosis. So someone who might have instability in their lumbar spine and just starting to have things break down and asymmetries develop, that can lead to a scoliosis as well. That type doesn't necessarily always follow the right thoracic left lumbar of the idiopathic adolescent type, just because it's more of a traumatic, kind of a over time trauma, degenerative type of process. So things can kind of, just depending on how people use their bodies, right? And what they typically do in patterns that they use.
And how old could that be anything after adolescence?
Yeah. I mean, it just depends on what you do with your body and what it's been through and how your body compensates for.
Because that's an important point that not a lot of people would be aware of, how you use your body and what has gone on in your life and what you have to compensate for.
Right.
There's so many different potential influences that can influence how you actually use your body. It's not something, because to a lot of, I think people hear the word scoliosis and they think of one thing. They just think of curved spines, but not understanding that it can mean different things at different ages, and they're not necessarily going to all be the same origin. well, no, I mean, they're all focused in the spine, but
Yeah.
there's different context around these labels of scoliosis. It's not all the same thing.
Right. And then there's actually one other category. So I specialize in the younger people. So I'm much more well versed in that. And my coworkers are going to talk more about the older population. But there's also a neuromuscular scoliosis. So kids with cerebral palsy or Down syndrome or muscular dystrophy or some other main problem going on. For example, in muscular dystrophy, you know, those poor boys, if it's Duchenne muscular dystrophy, or people, if it's a different type, get very, very weak and a lot of times end up in wheelchairs. And so they have to try to figure out how to compensate for the weakness. So if they're left-handed, let's say, they may use their spine and their body to get their left arm where they need to put it to function. And so if they're always doing a motion, their curve may develop outside of the typical pattern, but it's a different type of curve. It's not idiopathic scoliosis. So I just want to be clear. And that population, when there's potentially, like for cerebral palsy, when there's potentially cognitive impairment or such spasticity and tone that you can't control your body, the PRI and the Schroth is really hard to make a good outcome, have a good outcome, just because the person isn't able to specifically sense and feel and direct their body to do exactly what they want it to do. But there are some components of the treatments that we can use, just even positioning. So that I just don't, I want to make sure that's a kind of a delineation we respect. It's not that nothing will work for them, but it's just much, much more challenging to manage it in that population.
Okay.
And the population that really I have the most experience working with is the adolescent, typically developing mostly young people who, all of a sudden develop a curve. So just to be clear about that.
Well, that's a perfect segue into treatment. Because no one really knows what to do in terms of, there are people who know what to do, but most general public, a lot of times they're hearing conflicting information. Sometimes they're given information that seems like, I guess they're probably going to doctors with different levels of experience, seeing specialists with different levels of experience and perspective, and they'll probably start to hear different things. So from your perspective, let's say you're working with a juvenile, all right? And what can you do for these children in terms of treatment so that you have a chance of not getting not getting the curve to get more extreme? I don't know if I just said that correctly, but I think
I'm with you. I will say, Neil, before I answer that question, I do just want to point out one other type of scoliosis.
Sure, go ahead. I love your completeness.
No worries. So, with younger people, there are sometimes they kind of grow asymmetrically. And so they might develop what we call a functional curve. Okay, so this is the type of person where you might look at them and standing from the back and you say, your hips are kind of over here and your shoulders, you're not quite lined up right. But when they bend forward to do the Adams forward bend test, there's no rotation. Like there's no rib cage asymmetry. So their back looks very even. But when they stand up, it kind of just looks like they're kind of not lined up very well. And sometimes that just goes away. Sometimes it goes away. Sometimes it leads into an idiopathic scoliosis, and we just really don't know who gets what and who and why. For what I mean is we don't understand fully why some people can get a functional curve and it goes away, and some people, their curve turns into a more structural curve with the rotation piece, so that you do see the rib asymmetry when they bend forward.
Can you just explain that functional curve versus structural just a little bit more?
Yes, and I have a great photo.
Okay, and so is the functional curve more of a temporary state of affairs because of a growing body?
That's what I've read and what I understand it to be. So it's in a person who's growing.
Okay.
And it goes away. Sometimes the curve that you might see on an x-ray, a very mild 7, even maybe 10 degree, or maybe in the low teens curve can go away. You can see the deviation, and then they bend forward and it's perfectly level. So that's the definition of a functional curve. If there's no torsion yet, there's no twist, there's no tension and rotation to make the rib cage get higher.
So if you're saying you observe a shift of the pelvis and the rib cage in kind of opposite directions, and you're thinking this person must have scoliosis, but they bend over and there's no rotation, then likely we think at that point it's probably just structural. Or
if there's no rotation, it's functional. When you do when you do start to see the asymmetry, then we think it's getting structural, meaning they can't get out of it. We can't reduce that rotation like immediately. Now, you talked about treatment. Over the course of treatment, we can start to see it kind of come down. A lot of times we see great results, but there are some people, despite anything you try, and we'll talk about what the treatments are in a moment, despite what you do, the curves still can progress. And that's one of the most frustrating things about my job, is that I have to look a parent in the eye and say, you know what, we're gonna try these things and we're gonna make the best effort we can, but I cannot guarantee you that this curve won't get worse and maybe potentially need surgery. Like it's really hard to predict who's going to do well and who's not going to do well.